Hi, once again, good morning to everybody. Welcome to the ASCVPR Fall Conference. This is an awesome conference. It's definitely been an incredible year. It's been a pleasure to serve as president and get to bring some new innovations here to ASCVPR. So today we have some great people speaking today. A lot of our mentors on the board, and it's going to be a good conference with a lot of good topics. So just recently we all attended the ASCVPR annual conference in Portland, and that was a fun conference. We came home with a lot of takeaways. There were some really good, interesting topics, and we're going to go over a brief overview of those topics. It's such a big meeting that we have to break up into groups, and each of us gets to attend different lectures. So it's good to come back home and we get to dissect some of that information that we talk about. So there's definitely so many people to thank in planning this conference today. All of our planning committee, Stephanie Barton, Lauren Ederstich, Mindy Teeter, and Carolyn Wagner. Also Jane Langley. So special thanks to all of you guys for helping out with planning that conference. And special thanks to all of you for coming. I know it's a Saturday morning. We definitely thank you for taking some time out of your day to come out here and improve your education and learn a little bit more about cardiac rehab. So that goes to show just a lot as far as how dedicated you guys are to the field. Cardiac rehab professionals are very unique in the sense that they will give up a Saturday in perfect weather, Arizona. For all of those live streaming, beautiful weather. Everyone would probably be exercising right now if they weren't here. But today, you guys are taking your time out of your day, and that's awesome. We're all here with the end goal of improving patient outcomes, and we do all of this for our patients. So hopefully we can translate some of this into real world action and help our patients. So special thank you to AACVPR, they're our national organization. One, they put on the conference, and two, they are amazing when it comes to helping us out. I stepped into this role just recently, and I've asked a lot of questions, tons of emails, and they're always very responsive in that sense. So we've been a joint affiliate with them, and things have been really good. So special thanks to them. And also a huge thanks to our sponsors. So amazing, generous contributions from Zoll, Boston Scientific, and from GymSource, who helped put this conference on. So round of applause for all of us. So new news in AACVPR, I want to definitely present. We have a new president at AACVPR, Ms. Anna Mola. Anna Mola she's a wonderful president. I think she is so energized. She's been very dedicated to the field for decades. So this role is very fitting of her. So for all of you professionals out there who are looking for good guidance and a good mentor, she would be more than happy to offer those sorts of things. And definitely words of advice for you guys in the cardiac rehab field. She's one person who I feel like her energy levels have never quit. She is, being that she's been in the field for decades, she's just very high energy, explosive, Boston personality, wonderful person. So welcome, Anna, and we really appreciate you having you as president. So, like I said, the annual conference, amazing. One of my big takeaways was the Million Hearts initiative started by the CDC That's a joint effort from the CDC and also for the Center, Medicare, and Medicaid. So altogether, the CDC and Medicaid, we've got together to form a package to help cardiac rehabs, to help us address some of the barriers that we all face. And the big ones there are referral rates. As you know, referral rates for cardiac rehab for eligible patients are a dismal 30-35%, depending on the studies you look at. Also, looking at just overall enrollment in cardiac rehab and participation in cardiac rehab. So they really target and address those three barriers. Million Hearts is a evidence-based practice packet for all of you professionals. And everybody, I think everyone should know about this because they are tackling these issues, and not only are they tackling these issues, but they are fierce in their goals. In fact, they aim to prevent 1 million heart attacks. So between 2017 and 2022, one of their big aims, one of their big goals, is to prevent 1 million heart attacks. They aim to increase the use of cardiac rehab in eligible patients, and their goal is 70% referral rates for cardiac rehab, and that's huge. You know, since we're sitting at 35% right now, we need ambitious fighters who are stepping up to the plate and really being advocates for cardiac rehab. So big thanks to Million Hearts. Can't say enough about them. If you are here and you're taking notes, that's a big one to make sure you write down, Million Hearts. So Million Hearts came out in 2018. That's when they released the cardiac change packet in 2018. But they didn't stop there. Like I said, this is a fierce, ferocious group who has so much motivation and drive. So just recently they have a new 3-year, $6 million project known as the Take Heart Initiative. Okay, it's another good one to write down, Take Heart Initiative. Now, that is going to be a program that your hospital can sign up for free. And what they do, the Take Heart Initiative will help support the implementation of the cardiac rehab change packet. So cardiac rehab change practice, or that packet, went through and identified ways to target these barriers and address them. And now the Take Heart Initiative is the second part of that, and they're going to help implement that cardiac rehab change project, or the packet. So these are a ton of different ways. They go about this a lot of different ways. They're going to have coaches for cardiac rehabs to talk to. They're going to kind of line up your key conversations in the hospital as far as who you need to talk to, whether it be CEOs, CFOs. They're going to help you get your presentations ready so that you are pitching and presenting to the right people, the game changers, the people who make the decisions in the hospitals. Now, I bring this to light because after having some conversations with the CDC, Arizona as a whole, very, very few cardiac rehabs are participating in this program. And we should all be participating in this program, but we are pretty low as far as our numbers go, and it is across the nation. So that's definitely some ground that we can improve on. So once again, that's the Million Heart Change Initiative, and that the project is called the Take Heart Initiative. So there'll be some resources. Right now there are some resources on the national page. If you go to the ASCVPR.org under resources, you can find out a lot more about the cardiac rehab change packet and the Take Heart Initiative. And when I say relentless, they even now just released their tobacco cessation program specific for cardiac rehab. Okay, so That's another downloadable tool that we have at our fingertips. And with the end goal, helping our patients improve and hold off that cardiovascular disease and do everything we can to decrease cardiovascular disease. So, have a special recognition from the ASCVPR. We did receive a plaque and an award that I'd like to present to. This award is for celebrating 30 years of joint affiliate membership with ASCVPR. So, in 30 years, it's been a long road. It's been a lot of ups and downs, and people who have really kept this torch lit and kept this program alive, and now to see it thriving in the situation that we are right now. Lots of participation and doing huge things for cardiac rehab. So I would like this award to live with Holly Bright from Mayo. She was one of the first who started with this organization. So we've been a joint affiliate with ASCVPR since 1989. So one other very special person here who knows a lot about the history of ASCVPR or ASCVPR as we stand is Carolyn Wagner. And I'd like Carolyn to come up and say a few words. As far as our history goes, she's very knowledgeable in that sense. So welcome to the stage, Ms. Carolyn Wagner.
I was just reviewing and talking to Ruben a little bit earlier. I have on file, and I'm going to get it to Jane, a little what we could piece together about our history. And from what I can tell is we first tried to incorporate with the Corporation Commission in 1985. And Holly tells me she feels the early meetings were in like somebody's home. And Janelle and Holly have been around since the very beginning. And I want to remind some people that in the early years, Kent Smith, right guys, Kent Smith from the Arizona Heart Institute was a really active member, and I don't know if you guys know, but nationally there's a national award that's the Kent Smith Award. So Arizona has done some great things. Something I want to point out, we've been an affiliate for years and years, but when did we first start? It was when you were president, right, Holly?
Just after. We
yeah,
laid
so
the groundwork
joint affiliate now for about 5-6 years?
I think 4.
4 years, which is really good, and I will tell you, the joint affiliate membership is kind of a deal. It's like it was up to $285 a year, and we're only paying like $215. Really good deal, and it includes education, so really think about becoming a member of your national society. A couple other things that I always am interested in is, in the years past, I don't know if you guys know this, but Joe Piscatelli spoke at our annual seminar a couple of times. You guys all know him, right? Okay, all right. And the other thing is we have had over the years a few fellows, people who have applied for and received fellow status. Bonnie Fay, who used to work at St. Joe's, was a fellow. And Bonnie Fay's, I haven't looked at the latest edition, but Bonnie Fay's name was on the pulmonary guidelines as somebody who highly contributed to that. We just got a new one, and I'm not sure if her name's still on it. But she was a fellow. Chuck Kitchen became a fellow who used to work at St. Joe's. And Jeff Alexander, who is at AT still and works in the health science and sports role. But Holly Bright became a fellow, I'm going to guess, Holly, 14?
Yes.
2014. Now, she's our only fellow currently active in the state society. So some of you out there, like Janelle, start thinking about this. I'm about to retire, or I think maybe about doing it, but they do want you to be very active in the National Society too. So get active. Think about joining a national committee. I've always thought it would be so cool if Arizona got somebody on the certification committee. Come on, that we could talk to somebody out there. Yeah, I just think, so, you know, it's just been a great society. We had a couple years where life is lapsed a little bit, but I think we're going great guns, and Ruben has certainly helped, Ruben and Jane are certainly helped dragging us into the 21st century and some technology, and we are so excited about that. And so let's keep the momentum going, help out, volunteer to help, and if anybody knows anybody south of the Phoenix area, we get a lot of people north, but let's get those Tucson people. Human has always been fairly good about coming, but let's get some Tucson people interested. If you know anybody, if you deal with anybody, say, hey, get involved in the membership. Particularly now that we're thinking about live streaming, they could at least do that. All right, Ruben, do you want me to talk about anything?
All right, so it is my pleasure to introduce our keynote speaker today. Our keynote speaker has been a nurse for 30 years, so better than a nursing field, 27 of those years in cardiac. She's also worked in cath lab for 16 years, and we have the pleasure of having her work in cardiac rehab for 2 years with us. So she's seen the cardiac rehab field and cardiac sciences from every aspect. She's now currently serving as TAVR coordinator, and she is the structural heart coordinator for Banner. So I proudly bring to the stage Ms. Melanie Schultz.
Good morning. So, Ruben approached me about a month ago and asked if I would speak, thinking I'm going to get up here, talk about 5 minutes, sit back down, be all done, and then he starts teasing me, oh, but you are the keynote speaker. So I wasn't really nervous even at that point until this morning. I'm sitting on my patio talking to my daughter who's in Denver, and she goes, you don't like to public speak. I go, no, I don't. I don't know what I'm doing. But I do like to educate patients. So you guys are going to be my patients today. We're going to go through the TAVR program. So TAVR came out about 11 years. It's a transcatheter aortic valve replacement. And, whoops. And you'll have to bear with me because I am not technologically smart. So aortic stenosis, as we all know, is a progressive disease where the leaflets of the valve become stiff from calcium deposits. And the reason this becomes a problem is because as they get stiff, they can't open and close. So when they're shut, they let leakage go. That's where we come up with our shortness of breath, our edema. And then when they close, they don't close tight. So there's a lot of problems with aortic stenosis. It is a slow developing disease. You don't just wake up the next morning and have aortic stenosis. And usually your cardiologist is following you for a few years before you get to the point that we can fix something. We have parameters of the aortic valve that we look at on an echo. And to be severe aortic stenosis, your aortic valve area needs to be less than 1, and the mean gradient across the valve needs to be greater than 40. So those parameters are important to watch as the patient progresses. So this kind of shows you what a disease valve looks versus a normal valve. Like I said, normal valve, they open really nice, they close really tight. Aortics, they don't open so far and they don't close tight. So when you're listening to a patient and you have that heart murmur, you're hearing the turbulence trying to go through that small hole. That's what causes your heart murmur. So some of the risk factors that we calculate on what's called an STS calculator. That is the Society of thoracic surgeon's calculator. So we put in the patient's age, any comorbidities. Some of them are hypertension, diabetes, strokes, kidney disease, if they're in heart failure, which most of them are, and they're usually a class 3. By the time we get them to surgery, previous MIs, arrhythmias, or other valve problems. So sometimes these patients not only have their aortic valve affected, they have their tricuspid and their mitral valve. So we put all this in a calculator, and it gives us a percentage. Before August of this year, we had to have either intermediate or high risk or inoperable patients. They were the only ones that qualified for TAVR. Now, since August, the FDA decided that we are ready to do low risk. So we're going to start seeing a lot younger and a lot healthier patients come through. And this breakdown is just kind of showing you the STS scoring. So anything, and it's not 4%, I don't know why that says 4%, but it's 3% to 8% is your intermediate. Anything above 8% is high risk or inoperable. So there's been traditionally one way to fix a surgical, or fix an aortic valve, and that was the surgical valve. So when we do a surgical valve replacement, we're actually opening the chest, going in the heart, cutting out the old diseased aortic valve, and then replacing it, sewing in a new one. So it's more like a ring. There's mechanical or there's tissue valves. Mechanical valves last longer, but they have to be on long-term anticoagulation. So these older patients that are at high risk for falls, or if they have GI bleeds, they can't do the mechanical valve. Surgical valves typically last between 15 to 20 years, but now we have the TAVR. So the TAVR, there's two types. There's an Edwards, which is the Sapien, and there's a Medtronic, which is the Evolut. They look vastly different. They are both tissue valves. The Edwards is a cow tissue, and the Medtronic is a pig tissue. And we deploy those with a catheter. So it's kind of like what I did in the cath lab. We take catheters up the groin, we go up through the aorta, drop down into the valve, and then blow a balloon up inside of the valve to deliver the valve. So here's where we're going to hit some dilemmas since low risk came out. Any patient that I talk to, and I say, well, we can do surgical or we can do transcatheter. Well, of course, I tell them surgical valve will open your chest. You're going to be in the hospital for about 5 days. You're going to recover over 6 to 8 weeks surgically, but then you're going to really feel like crap for the next 3 to 6 months. So, or I can poke your groin, we can deliver it, you have a 5-day recovery, and you're on your way. Of course, everybody's going to say, I want to go TAVR. We do have a dilemma there. So TAVR has been out for 11 years. We have about 10 years of study. Right now, we're neck and neck with the surgical valve as far as durability and complications. Oops. So we have to really talk to the patient. So the cardiologist and the cardiothoracic surgeon who consult with these patients before the procedure really have to lay it out for the patients. And this is where you, as the inpatient cardiac rehab, if you have a patient laying in the bed and you're seeing them after a cath and they're really confused, this is where you can come in and educate them. So if you have a 40-year-old that has aortic stenosis, which is an early stenosis for that age group, and you're talking about surgical versus transcatheter, all we know is that the durability of the transcatheter is 10 years. That's all the study we have. So we don't know how long it's going to last before it restenose. So you have to take that into account. You have a 40-year-old, say it restenose in 10 years, you can go one more time inside that valve, but then you're stuck. So now you've got a 50-year-old that may get to 60, but we can't do anything past that point. Once you place a TAVR in a valve, you can't go back to surgical. You can only go transcatheter again. So that's another problem that we have. So it's really going to lie within the cardiologist and the cardiothoracic surgeon doing what's best for the patient. And along with the longevity, we've got to look at the durability, because the younger the patient, most likely they're going to be more active. So we need to make sure that as cardiac rehab, you are preparing for that younger, more athletic patient so that you can get them up and going quicker. This is some of the low-risk trials, some of the data between your SAVR or your open heart versus your TAVR. We're pretty well neck and neck. We have a little bit higher rate a pacemaker after the procedure just because our valves sit a little bit higher than a ring. So we get in that electrical tissue a little bit more than just sewing in a ring. As far as vascular complications, you would think we would be highly more, but we're not. We're just about the same. So what I do is I meet the patient at referral, and I work them through the process. So they have quite a bit of a workup. They have to do a left heart cath to make sure their coronary arteries are clear. Don't want to be putting a valve in if we have major blockage in the coronary arteries. They take care of any blockages they have with PCI. We do a CT angio. This is a CT angio. So we want a roadmap of how we're going to get that catheter replaced. And you can see here, these are the femoral arteries going up into the aorta. And then we take sections. Those little round circles are sections of the artery. We need to make sure that it'll accommodate a 14 French sheath. And then we also want to look for the plaque. So the little white highlights there, that's calcium. So we want to make sure that there's not a lot of occlusion on those femoral arteries, that we can get the catheter up, and we also want to make sure that we're not going to knock any of that off. If we knock that off, we can cause a stroke. So we do the CT angio workup. This is actually what is sent to the vendor, and this is one of their reports. We do an echocardiogram, of course. And then I do a 5-meter walk test and a KCCQ at the time of their pre-op testing. And that kind of gives us an idea of where the patient thinks they're at. That KCCQ is important because a lot of times my patients end up in my office and they're in wheelchairs. They can't walk from here to the door. They get so short of breath, they're so tired. So they fill out the KCCQ. Do what?
What does KCCQ stand for?
Kansas City. I knew someone was going to ask me that. I did write it down.
What are they tracking? Is it a quality?
They're tracking how the patient feels about their shortness of breath.
Okay.
How they feel they can do physically, how far they can walk without feeling short of breath, if they have to sleep sitting up, and then how happy are they with their life the way it is right now. So most of the time, not all the time, but most of the time I see a really big increase in how satisfied they are with their life after we deliver the TAVR. The 5-meter walk is a walk test where I just time them walking the 5 meters, see how short of breath they get, see if they have to rest in between. We do it 3 times. And that kind of tells me how frail they are. And we don't do the 5-meter walk at the follow-up, so we do it before. So this is kind of what the workup is before we get to TAVR. All of this takes about 4 weeks to do. And then we set up the TAVR. On the day of the TAVR, let me show you this. So the round picture here, this is called a hockey puck. So if we were looking down from the head onto the valve, this is your aortic valve. The little spots here are the leaflets, so that's how we mark the leaflets. All of this is calcium. We want calcium on the valve, that's what helps the TAVR stay in place. If we don't have any calcium on the valve, it might not enter, right? So we did just do our first case of aortic insufficiency. The patient had no calcium on the valve, and literally we recaptured the valve 10 times before we finally got it deployed because it kept wanting to shoot out. So, not fun. So you want the calcium there, and then this is your aortic arch, and this gives us a picture of exactly where we're going to land the valve. So you can see these patients have quite a bit of calcium by the time they go to TAVR. So another thing that I do as coordinator is I coordinate everybody that's going to be in the room that day. So there's about 14 people in the room when we do a TAVR. We have a full cath lab team, we have a full CVR team. So as I say, I heard cats that day. We want to be ready for anything. So some patients, they're given the option, if we get into trouble, if we poke the artery, or if we poke the artery, or poke the aorta, or if we fracture the valve, do they want us to go open? Do they want us to convert to open? Some patients say, no way, I'll meet my maker. Those are the patients that have had open heart surgery before. And then some patients say, yeah, do everything you can for me. Fortunately, I've never had that happen. But we have both the surgical team and the cath lab team so that if we do have to open, we're ready to go. We do these in the hybrid room right now. I know Banner Heart is getting ready to start doing them in the cath lab suites, just because staffing and get the machines working correctly when they're in a room that's used all the time. And then they usually go to CVICU for the first night. The reason they recover in CVICU is because, like I said, we're right in that AV node. So we want to make sure that we don't cause a heart block. If we cause a heart block, then we were going to put a pacemaker in. Normally, we're going to see heart blocks immediately as soon as we drop the valve. Sometimes we'll see kind of a bundle branch for about 6 hours, and then it'll resolve itself. If we notice any kind of changes in the rhythm, we will leave that temporary wire down, just in case we need to pace or lead, sorry. After that, first 24 hours in CVICU, they normally go to a step-down unit. And in my program, they go home Saturday or Sunday. Some programs send them home the next day. I get very nervous when my surgeons say I'm going to send you home on Friday, especially when my patients are 90s. So I would prefer my patients to say Saturday or Sunday, just to make sure they're good. So some of the things that you can look forward to in cardiac rehab. So like I said, these patients, they don't just wake up with aortic stenosis. It's a slow, progressive disease. So they've deteriorated over a long time. Most of my patients say, I just thought I was getting older, which is true, they are getting older, but they're getting weaker because they're short of breath, they're tired, so they don't feel like getting up and moving, so their muscle mass has deteriorated. So those are the patients that you're going to start kind of low in cardiac rehab and slowly build them up. We want to monitor them because we do want to watch for any arrhythmias at that point as well when they come to you. And then the low-risk patients, those are the patients that they're probably going to come to you, and they're the ones that you're going to have to kind of hold back a little bit because they're going to want to go because they're younger, they've been more active. I had a tennis player that we just placed a valve in, and he was like, the next day I saw him in ICU, he's like, so when can I play tennis? I'm like, not for a while. So those younger ones, you are going to have to kind of hold them back, slowly build them back up, but you will be able to see better results and quicker results on those patients. Some of the changes that our low-risk patients will have to really get pounded into their head are lifestyle changes so that this doesn't re-stenose quickly. Dietary changes, getting into a routine of exercise, smoking cessation is one of the biggest things. That's one of the biggest causes of aortic stenosis. And then medication compliance. My patients go home on Plavix for 3 to 6 months. It's not like a stent. They don't have to be on it for a year. And then there's no blood thinner since we're tissue valves. So I'm going to hand it off to Ruben. He's going to talk to you a little bit more about cardiac rehab.
Yes, thank you.
And the TAVR patient. Any questions about, yeah?
I know you said there wasn't any data on after 10 years. What do the valves that are 10 years out look like now? Is there any data on that?
Right now, we're neck and neck. Like as far as complications and durability with the surgical valves, we're lasting just as long as they are. The complications are basically the same. Bleeding, valve fracture. We have a little bit higher risk of permanent pacemaker even at the 30-day mark, but we're neck and neck with everything. So and my reps tell me that they totally expect us to hit that 15, 20 mark. We just haven't been doing it that long, so we don't have the data to say, oh yeah, we're going to last 15 to 20 years as well.
So when the TAVR first came out, there was a fairly high risk of stroke. Has that been, I couldn't see all the numbers and I apologize.
So stroke has come down a lot. And we can go in, so if I have a patient that has highly calcified femoral arteries, we can go transapical, we can go subclavian, we can go carotid, and transaortic. We weren't really doing that at first, but they developed those techniques that, and most of my cardiothoracic surgeons are, I mean, that's their field. They love that. And I come to them and I say, oh, we have bad femorals. They're like, all right, I need to take first seat. So there are other ways, but stroke is, I mean, I think it's like a 3% maybe.
What's the percentage?
I think it's a 3% is where we're at.
Is there a healing time frame, or what happens in the healing process?
Yes. So these patients go home with, just like if they had heart cath precautions. So they're not going to lift, push, or pull anything greater than 10 pounds for the first 5 to 7 days. They're not going to sit in any water, so no hot tubs, bathtubs, or swimming pools. They can shower right after. And then no driving for a week. So it's basically just the groin precautions that we're worried about. If we go an alternative access, of course they'll have an incision that they'll have to watch. It's very important for these patients to know that if they have any signs of infection, I always tell them, because I do TAVRs on Thursday mornings, so they go home over the weekend, and I'm not willing to give up my weekends to round on them, but they go home on the weekend, and I tell them, even if you're home and you develop a fever of 100, you notice you've got some drainage going or something, call the doctor, because they'll put you into the online, because we need to start antibiotics immediately so we don't get any infection on the valve. Another thing that I do from the point of referral is make sure that their dental hygiene is good. So if they haven't seen a dentist in 6 months, there they go. A lot of my patients get full extraction before we go forward, which is awful, because some of these mature people have not gone to the dentist for years and years and years, so they get dentures before they come and get their TAVR. Oh my gosh, there's so many questions.
Our hospital just in the last month started doing TAVRs, and we had a patient referred to us who was not eligible for a TAVR because she had breast implants. And I tried to read about it, and I ran across something that said they weren't candidates, but it didn't say why.
I've never heard that.
Okay.
I'll have to look into that. I have never heard that.
Interesting.
That's interesting.
I would say along the lines of healing, we are going to be seeing a lot younger people who are getting much higher exercise capacity. Is there a risk of dislodging or anything like that if we have people who are going to do really, really vigorous things 2 weeks later?
No. So the valve, and that's why the calcium is so important. The calcium kind of anchors in, but once the valve is deployed, it's there.
So there's no
Yeah.
really process there.
Does the tissue grow around it?
Yes, and I was going to bring my valves. So they have a model back there. So on the Edwards valve, I don't know if that's the Watchman. I don't know if we have Medtronic. So on the Edwards valve, it kind of looks like a crown. And on the bottom there is a material that actually the tissue forms around it to anchor it in spot. Medtronic is more of an hourglass and titanium sheath that forms in there, but it flares out on the top and the bottom, so it hinges that way.
You talked about in procedure, I put the pacer lead in there. Do you just leave that in there? Or
We do usually, if we see anything during recovery for that, we deploy it, we do an echo right after to make sure we're well seated, we don't have any leakage around the valve. If we see anything, we'll leave that temporary pacer lead in overnight, and if we're still seeing signs of a heart block or a huge left bundle, we'll go ahead and place a pacemaker at that time.
One of my nurses was wanting me to find out, do you have a percentage of how many people need pacers after TAVR?
5 to 10%.
Do you see a fair amount of AFib also, or?
A lot of my patients do have AFib. I don't have a percentage, but a lot of them do have the AFib, and then of course they're on the blood thinners. So yeah.
Regarding Holly's question about the tissue growing around it, how soon does that happen?
I don't have a time frame. I have only heard of one TAVR valve, and I just heard about it this week, and it wasn't in Arizona, that actually it somehow went into the left ventricle. So I don't know, and it was a little while after surgery. I'm not sure of the specifics. I don't know any details. I was just talking to an echo tech that had actually seen the echo of it as it's bouncing around. So honestly, I don't know how long it takes for it to lodge. As soon as, like I said, as soon as we deliver the valve, we're doing an echo. So we know that it's well seated. We know there's no leakage around the valve. And then we also do a 24-hour post echo to make sure that we're still well seated. These patients do go into the National Registry, so they are followed for a year. We see them at 30 days and at a year. We do a repeat echo, we do labs. They see the cardiologist in the office. All of that comes to me, and then I send it into the registry. So they are getting those echoes throughout the year to make sure that we're still set and good.
We had a patient here that had a
TAVR, and I guess it was moving, so they actually had to pull it up higher, place it, and then put another one in.
Inside, yeah.
And the patient was very fluid overload, so we were concerned with, were they competing against each other, or, you know what I mean?
Yeah, I don't know. And you can, so the Medtronic valve, you can actually deploy to 70% and then recapture if you're not happy with the placement. The Edwards valve, once you deploy, it's there. But you can snare it and adjust a little bit, but you can't totally recapture it and replace. And that's when I had the aortic insufficiency patient, we were using a Medtronic valve because they are used more frequently in those cases, and because you can recapture. And like I said, we recaptured like 10 times. I don't think anybody was dry after we left. Any other questions? Hopefully I answered
All
your
right,
questions.
thank you, Mel. And you are a great public speaker. I think Melanie is this interesting all the time at work. So I think she's definitely a great mentor to all of us at work. But very interesting topic. So we're going to shift gears here a little bit and talk a little bit more about cardiac rehab and what we're seeing in our TAVR patients right now, what we can expect, and definitely some precautions we need to be taking with our TAVR patients. So our TAVR patients right now, we're getting the high-risk TAVR patients. There's going to be a little shift here where we'll start to see the low-risk patients, but as of now, we're seeing those patients who are a lot more frail. So I want to take a look at this graph and talk a little bit about VO2 max, and it's a very important measurement in cardiac rehab. Now I know that the majority of cardiac rehabs do not measure VO2. Okay, so relatively expensive test. However, the testing for VO2 max is just getting better and better. The price of getting an accurate VO2 max test is coming down. There's a lot of different algorithms out there and wearables that are going to take over the market. And I really do believe that we're going to start to see some clinical VO2, just bracelets and watches and those sorts of things. So this is why I want to discuss this measure. Also, because even though we don't measure it, this is the biggest variable that we're improving in cardiac rehab and TAVR patients. So if you take a look at that y-axis, here we have VO2 is at 20 mLs per kg per minute, and it goes up 30, 40, 50, 60, 70. So 70% or 70 mLs per kg per minute VO2 max is looking at your aerobic athletes and those sorts of things, and 30s to 40s and your sedentary patients, and then your frailty threshold there on the bottom. So if you look at the x-axis, we see the age with individuals as far as that goes. So you can see all of us in human nature progressively fall toward that frailty threshold. Okay, so you can see sedentary individuals hit that frailty threshold a lot sooner. Even as soon as 60, 65 years old, they're falling below 18 mLs per kg per minute. Now that number is very important because when we're looking at a frailty threshold of anywhere from 15 to 18, that is definitely indicative of a patient who is not independent. Okay, maybe they're in assisted living. Those are patients who are on a transplant list, and they need a lot of help just in carrying on activities of daily living. So what's going to be important here is when we look at a lot of the research, you can see when you do get a TAVR patient, they are in that frailty threshold, but with cardiac rehab, in as little as 8 weeks, we can see some of those patients are able to get out of that frailty threshold. Where you're not frail, they become more independent, and that's a huge part of cardiac rehab. giving back life to our patients, giving them independence and those sorts of things. So this is also a good graph just to show for all of you how important exercise is. Looking at the aerobically trained individuals, those aerobically trained hit the frailty threshold a lot later in life. So I'm projecting to hit the frailty threshold at 108 years old. I hope. If my calculations correct. So this is a great study. I took a look at the exercise training that improves exercise capacity and quality of life after TAVR implementation. And this was a really good study to take a look at just how important cardiac rehab is. This is done by ASCVPR out of Germany. Him and his colleagues rounded up 30 patients, so a little bit of a small sample size. Nonetheless, this is pretty reflective of what we see in cardiac rehab. So they randomly assigned 2 groups. One group was a training group. They trained for 8 weeks of supervised exercise, and the other was a usual care group. So the usual care group, when you look at those on studies, it's usually they were encouraged to exercise, maybe given pamphlets to exercise, given all the advice and motivational speaking in the world, but it wasn't supervised. And so 9 times out of 10, that patient didn't necessarily follow the exercise guidelines. So really important to look at that first line. I know this is a busy slide, but we're going to take a look at a few things here. So I'll show you what I'm looking at here. We're going to look at this top line here. So when you look at the top line there, the baseline training group entered this study after getting their TAVR well at 12.7 mLs per kg per minute. Now go back to the last slide and think about where that lands on the frailty line. That's well under the frailty line. Okay. After cardiac rehab or after 8 weeks of supervised exercise, that VO2 max came up to 15.9, and some even more than that. It's a plus or minus 5. So a significant increase in VO2 max. Ideally, this is only an 8-week study. I really think that if you would push this out to 12 weeks, we would have seen improvements to bring them out of that frailty threshold. So let's look at TAVR patients now in the usual care group. This is the group that we're assuming did not exercise. The baseline they entered with a VO2 max of 15, which is a little higher. However, after 8 weeks of TAVR only and no exercise, that VO2 max is down to 14.5. Now we talked about the importance and the significance of that frailty threshold. These patients are going in the wrong direction. Okay, so to become more frail after a procedure, especially if you're not doing cardiac rehab and exercise, it's going to have bad outcomes, and that's why the referrals are so important. Even the phase 1 cardiac rehab, I think that's really where it starts. Being able to deliver this sort of information to your patients, and just letting them know that we want you to improve. Research shows if you don't exercise, you're going to go the wrong direction and become more frail. So very important. Now, TAVR patients, they do get to skip the whole sternotomy part of things, and that helps with healing. So looking at the muscular strength here, we're going to take a look at some of the resistance exercises they have them do. So we look at bench press, rowing, lat pull downs, shoulder press, and leg press. And these numbers are also very supportive of exercise. We see the bench press was at 29 kilograms upon starting. After 8 weeks in the training group, that went up to 34 kilograms. So big changes there, significant, and all of the exercises are very similar. I'll let you take a look at those. Shoulder press also went from 18 kilograms to 23, leg press 70 kilograms to 91. So all those resistance exercises improved with 8 weeks of supervised training. Now let's take a look at the usual care group. This group went in with we'll take bench press, we'll look at that first. They have the ability to lift 24 kilograms. After 8 weeks, they are right flat, still at 24 kilograms. And that's really the theme, the overarching theme for not exercising. We see no muscular adaptation there. Even shoulder press, everything stays pretty much the same. The lat pull down had a little bit of a decrease. But this study was good because this looked at the overall importance of cardiac rehab. Okay, so in those patients, when you see those patients, and you know, all of us have to sell cardiac rehab. We talk about how low our referral rates are, and these are some really important numbers that can help you in that. So our current TAVR patients, we're looking at the high-risk patients. We're going to start to see low risk, and we'll talk about those in a few, but our high-risk patients, they do come in severely deconditioned. I mean, they are battling the heart failure, the aortic regurgitation. So in cardiac rehab, we do have to start slow, okay? And we also have to progress really slow with these patients. And that's gonna, you know, well, I'll definitely leave that up to the clinical judgment of the team as far as the exercise physiologist and nurse goes. But using, you know, we're also going to use just standard exercise prescription methodology. But another big one, what the research has shown is we need to involve that upper body resistance training. Okay, so we get to avoid that sternotomy. So now we should really be implementing that, especially in the elderly population, who is the majority of these high-risk patients. So important during cardiac rehab for all of us during these sessions, you know, just be on the lookout for worsening dyspnea, angina, you know, syncope episodes, really the same signs that you would be looking at for heart failure. Because a lot of times, not only do they see the aortic stenosis, but the heart has taken some damage over the years, and these are heart failure patients who really truly do have some left ventricular dysfunction and those sorts of things. You know, be considerate of the anticoagulation medications they're going to be on. So if you do have a patient, you know, we all recommend home exercise and just have them use the utmost caution when they are doing their exercises at home because they are on the blood thinners and those sorts of things. Another big one to look out for, anemia. Anemia is pretty big with these patients. Do you see that a lot? No? Anemia?
Some,
Yeah, so these are, especially from an exercise prescription standpoint, you know, that's definitely hindering the body's ability to deliver oxygen to that working skeletal muscle. So when a patient is exercising and they are fatigued, it's likely that if they do have the pre-existing diagnosis of anemia, definitely make sure that they're staying on top of their medications, they're following that through with their physician. And if you have to send that FYI to the physician and let them know that, hey, this patient is, you know, showing some signs of anemia and concern about it, you know, those are definitely some things that we want to look out for. So all of these are factors that we have control over in cardiac rehab and considerations that we have to take in our high-risk TAVR populations. All right, on to the next. I'll make this graphic very easy to interpret. So we look at the y-axis there on the right-hand side. This is the one that's going up 30, 40, 50, 60. So I thought this graph was very important because we are going to start seeing low-risk patients who have higher functional capacity. Okay. And I'll take a walk over and explain this graph. So we're looking at our VO2 max numbers here on the right. And what we can expect to see, this is VO2 max in normal young adults. And you know, the more low-risk patients, and we'll see younger patients going through this procedure. So 30 mLs per kg per minute there in your sedentary population. Also in your normally active population, you'll probably see VO2s approximately 40, 45. And in your trained, conditioned these are people who are probably jogging 5 times a week, 30 minutes a day. These people are like walking briskly. And then you have your Lance Armstrongs and Lauren Entersiches out there who are your conditioned athletes who do some massive amounts of exercise. And those VO2 maxes are pushing 70 to 80 mLs per kg per minute. So pretty big numbers, and that's going to be important because when we get our patients, when we do get these low-risk patients, they're going to be able to do a lot more exercise, okay? And we're going to have to be able to deliver the best possible health outcome we can for these patients, and it's going to have to take into consideration that we're dealing with people who are going to get back to tennis, they're going to get back to their normal activities regardless, and it's going to be best for us to progressively up that exercise routine pretty fast. The progression would be a lot faster than somebody who's severely deconditioned. So even though they are healthier young adults, they do go through the same deconditioning, not at the same level as the high-risk patients, but there is some deconditioning going on. So really we have to focus on doing a good amount of aerobic exercise to make up that difference in deconditioning that they suffer from their aortic valve regurgitation and insufficiency. But we should be okay with letting them jog in 3 or 4 weeks. Obviously, we're going to start the progressive very similar to as we would in any stent patient. Extremely low levels of exercise for those first couple visits. And then, definitely bring it up to where they're probably exercising at anywhere from 4 to 6 minutes by week 3 or 4. Okay, so very low chances of this valve. We talked about it's set in there. It's not going to dislodge. It is set. And the more calcium we looked at earlier with Mel's speech, it's going to be safe. And we want our patients pushing those limits under supervision. And that's why we exist, so that we can get that patient strong and healthy. Okay? So, looking at the research, phase 1 and phase 2 programs for exercise are safe for these TAVR patients. The low-risk patients will be able to do a little bit more exercise, and I think that we don't have to approach it from such a timid standpoint. I think that it's something that we're going to have to, everything's going to be very patient-specific, so you'll know the workup on how you're going to exercise that patient. So, cardiac rehab, some of the big takeaways here, it does actually improve exercise capacity. It's going to improve exercise capacity for both your severely high-risk TAVR patients and your low-risk. And the moderate risk too, they all fall in there. For our high-risk patients, we're really looking at improving that functional independence. That's a huge role that cardiac rehab has to play in these patients. And improving those frailty parameters. I always visualize these patients as if it was my own family, my mother or father. The last thing we want is frail parents or frail patients, and we can do everything possible to get them out of that frailty threshold, more independent. That is cardiac rehab. That's what we do. That's why we get to see those success stories every day. So keep doing what you're doing. It's awesome. And really be encouraging to your patients. I know we talk so much about the exercise aspect in cardiac rehab, but the psychological aspect, the support that we give those people, so we become their social support, and we become part of their social network for those 36 visits that they're with us. So looking at it from a psychological perspective, also diet, we just continue to encourage them to eat healthy. Smoking cessation is a huge one, and I'll talk about how big of a contributor that is to aortic stenosis. So it is a chronic condition. It is a condition that even though you put a new valve in, the condition is still there. And you have now the new valve is slowly becoming stenosed. So everything that we can do to slow down that progress, that's what we have to do. That's definitely our role and our responsibility as professionals. That concludes my slide. I'd like to take any questions, or I'd like to invite Mel up here if you guys have any more questions about TAVR in general. We can answer those. What we're going to do now is if there are no questions, we'll break for lunch. We're going to be live streaming during lunch. If you are here for the live stream, we are going to be playing a couple commercials. They'll be on repeat. We will be back. At 12 noon. We will be back at 12 noon. And we have some awesome topics coming up. So starting at 12 noon, we are going to be talking about educational resources for cardiac rehab. What's new? What's out there? Next, resources for us to help our patients. Next, we're going to talk about medical marijuana, e-cigarettes, and alcohol. That's going to be good. Stephanie Martin will be the one going over the educational resources at 12 noon. From 12:50 to 1:15, Holly Bright will be going over updates in cardiac rehab and updates in the scientific exercise science literature. It's my pleasure. All right. I encourage you guys to all network. It's my pleasure. I encourage you guys to all network. I know there are a couple job openings out there in cardiac rehab that I was made aware of. I know Banner Desert is looking for an inpatient nurse to teach phase 1 cardiac rehab. That position is posted. So we have a very awesome nurse who will be retiring. I think we definitely have to pay tribute to Peggy Hansen, who I believe is streaming out there. She is going to be retiring. Wonderful individual who's dedicated her entire life to helping patients in the cardiovascular setting. Dedicated to exercise, and it's going to be big shoes to fill. I will definitely say that, but that job is opening up at Banner Desert for phase 1 cardiac rehab.
Banner Heart probably by November 1st has a full-time RN.
All right, yeah. So once again, if you didn't hear that, Banner Heart will probably have a full-time nurse position opening up as of November 1st. Anybody else have any?
Our health Shade has an alcohol exercise physiologist.
Awesome. Honor Health Shea, PRN, exercise physiology job opening currently. And
Havasu Regional still needs a full-time respiratory therapist.
yes, exactly. So
Desperately.
Lake Havasu, full-time respiratory therapist. And that position is definitely a position we've been looking to fill for a long time here in Arizona. But that staff is amazing. If you are interested in that position at Lake Havasu, check out the newsletter, the most recent newsletter on the ASCVPR website. It goes, we actually put the spotlight on Lake Havasu's cardiac rehab, and they are amazing professionals to work with. And whoever gets in there, I feel like they have hit the lottery, because that staff is amazing. All right, well, you guys may break for lunch. Feel free to mingle. Thank you for coming out.
That should connect.
So they tried it because of the way it's
I
mounted.
could see that it was working. It says it's active. It was looking at the slide that you had up. But this was stuck on
And in Edwards, because in Edwards
the
it's
first slide you had.
round
And
and
it
the
wouldn't show
Medtronic
me
has
what
these
that
struts
camera was
that go
seeing.
up.
And
So
it was
that's one
connected.
combination that's
So I don't know
We're very patient, so
why that.
with these lower patients.
stressed out.
We're gonna try to just get it back online and
Because we can go inside the valve once, and they are doing things now to but they are doing things now where if they need a bigger, it's called EOA, if they need a bigger area diameter, they'll go in with the balloon and they'll actually fracture the old valve. So they'll go inside the Edwards valve and they'll overinflate the valve, so fracture it. So they can go with the new valve and put it in. And that's scary. So I'm glad we're not doing that yet, but they are doing it down at Banner University all the time.
but now I don't have that camera working. It's the weird,
Don't
I
push
don't know
yourself.
why. I just
We're-
can't figure it out.
You're amongst very understanding people, so you just,
All the slides is washed out in a little pokey stone.
yeah, I will do that. And so is this live, like still cycling right now?
Yeah, manually.
Finish up your wonderful intellectual conversations. Thank you. All right, ladies and gentlemen, we are going to get started. Special thank you to Boston Scientific for providing lunch. Kevin, it was an awesome lunch. It was really appreciate Also, one more big thank you to Zoe for providing all that coffee to get us everywhere. All right, now speaking, we have the education topic we're going to be talking about right now. It's really going over educational resources that are out there for cardiac rehab. And this was another really big takeaway from attending the ASCVPR annual conference. Stephanie was able to attend a wonderful lecture, and she was very pumped up, as everybody who was there was pumped up with this last lecture. So, about educational resources, I would like to welcome to the stage Stephanie Barton.
Okay, and also just a big thank you to the Urbana Heart family for allowing us to have our quarterly conference here and all the work that you guys do. So today I'm going to be talking about one of my favorite sessions that I went to at the ASCVPR conference. And there was a couple of us that went that did attend this, and I just kept sitting there. I kept hitting Rich, and I was like, oh my God. I mean, it kept getting better and better and better. It was absolutely, yeah, he's still smiling. It was absolutely incredible. So I'd like to share with you, this is one topic that our department, I feel we could do a better job with our education. So this was the Cardiac College, a collaborative patient education program for cardiac rehab. This talk was presented by Dr. Paul O, which I did contact him this past week. And even though this is a public website, I did get approval from him to be able to talk about this presentation. So by a show of hands, has anybody heard of this Cardiac College? Cardiac College or Healthy University even before this? You have, and Carolyn? Okay.
He spoke like 5 years ago
Okay.
in Denver.
He was truly amazing. He's captivating. So I had never heard of it, and when he started presenting, I mean, like I said, I wanted more, which he kept joking around about. So he first, when he talked about, in his talk, he did a quote, which I love quotes, and so the quote that he shared was, "Teaching without learning is just talking," and that was by Thomas Angelo and Patricia Cross. And so those of you who know me know I like to talk a lot, but if I could teach my patients and then walk away with understanding about their disease, that's why we do what we do. So this website that is available to everyone as a resource. It's Healthy University. Be careful, what I was looking up when I was preparing for this, it's not healthyuniversity.com. Like I was trying to search, it's healthyuniversity.ca, because it's a Canadian website. So be aware of that. So in going through this, it's Healthy University, and then there's 2 different colleges. So I'm going to take you back to school. So we're going to start with the Cardiac College. Okay. So before I get started too, one of the neatest things about this website is language. So up in the upper right-hand corner, you can select which language you would like your patients to use. So if you have a Spanish-speaking patient, it changes the entire website for Spanish. I think they had French, Portuguese, Hindi, and I thought they had a couple other ones, but I don't see it on here. The neatest thing about this translation is that they didn't just translate word for word, they translated the cultures. So if it was a French culture or a Hindu culture, they went through the content and made it specific to that culture. So I thought that they really took that into consideration, and they didn't just translate the words, they translated it to make sense. When we talk about diet in our American culture, that's going to look way different for a patient that speaks Hindi. So anyway, I just want to point that out first. So with the educational platform, they have 5 fundamental program pillars. And it's treat heart disease, get active, eat healthy, feel well, take control. So we're going to kind of walk through each one of those. So click on treat heart disease. And then again, it's whatever appeals to the patient, whatever your patient is trying to learn. They have videos, resource links. And so just for time today, I'm just going to pick kind of 1 or 2 for each pillar. So the one that I had picked out was what my medications do for me. You click on the heart medications. I mean, you can pick every single one, what the medications do, their role in the heart, how they affect, side effects to look for. There's videos on how the heart works. I mean, again, just overview anatomy and physiology of the heart and everything about it. So that's educating from that pillar. So on Get Active, this was, I mean, there's so many amazing things in this website, but this one was really cool because this will help our patients with a home exercise standpoint. So if you tell your patients and give them this as a resource, they can do this on their off days. And if you go to resistance training, and again, I just kind of picked out a couple things. Resistance training videos, they have little YouTube videos with demonstrations of each of those exercises. So as we try to look for this for all of our patients, it's already done for us. So let's just pick that. And I'll just play it for a second.
Half squat without dumbbells. For this exercise, we will be using a chair. Stand with feet shoulder width apart, arms at your side, and draw your belly button in towards your spine. Keeping your feet flat on the floor and toes slightly pointed out, push your buttocks back and flex your hips to slowly lower your body to a half squat position. When you lower yourself down, shift your body weight back onto your heels. Make sure your knees do not go over your toes as you squat. A good way to check for this is to make sure you can see your toes when you lower yourself down. At the same time, raise your arms straight out in front of you. This will help keep your balance. This movement should feel like you were sitting back into a chair. Return to the upright position and bring your arms back down to your sides. Lower your body to a count of 2. Return to standing position to a count.
Okay, so you guys kind of get the idea. And I mean, they have an entire gallery of what those patients can do at home. I'm going to jump ahead, but at the end, I'm going to show you they actually have a diary log of aerobic exercises and resistance training. So all of these exercises that are listed here are on a card kind of piece of paper form that they can print off and follow that at home, and then use the videos to go along with it. So again, I think these are all these things that we wanted to give to our patients, but the time that it would take to put this together, it's already done. So the next one, so that's get active, and then eat healthy. There's a couple different things on here. There's lots of videos that you can click on. One about sodium. Sodium is usually always the one that we want to talk to the patients about. So information on reading food labels. I love this one, season your food without salt. So usually the patients will always ask, well, you know, what am I supposed to use? And so they have all these substitutes that you can use, and herb mixes, all-purpose flavoring. And some of these I actually had never thought about myself, so it's kind of interesting. And then another cool thing, are you eating the Mediterranean way? So we always know that the DASH diet and the Mediterranean diet are the two top diets that should be recommended for the cardiac patients. So this, you know, if they say, well, yeah, I'm doing it, well, now they can take a quiz to truly see how well they are as far as maintaining the Mediterranean diet. So that was kind of a neat thing. I took that on my own. I did pretty good, surprisingly. Not that I really follow it, but anyway, so that was kind of cool. And then if you click on making food healthy choices, again, they have more videos to talk about how to pick out cereals, how to pick out healthy drinks, oils, milks, you know, just great information. And then they also have tip cards. So these, the patients can print things off and take them to the grocery store with them, so that they can, there's a PDF form that has all of the grocery shopping tips that they can take with them as they're shopping to know which breads, which grains. I actually watched the one on the legumes. Did I say that right? So that one's the making healthy food choices. And I know I'm breezing through this pretty quickly, but I definitely encourage you guys when you get home to look at it and kind of navigate through the website on your own, because there's lots of good information. And then feel well, so this talks about the emotional aspects of cardiovascular disease, talks about sleep, stress and sense of control, anxiety, depression. So just wanted to click on this one. And there's a video there that I watched that does talk about living with stress and cardiovascular disease, that just the whole overwhelming, you know, all of a sudden now they said you have a stent, and now you have to take all these medications, and now you have to go to cardiac rehab, and you have to eat healthy, and how overwhelming it can be. And it talks about the differences between acute stress and chronic stress, and how they affect the heart. And then the neatest thing was on the relationships tab here, the sexual intimacy. I clicked on that too, and you know, sometimes this is something that the patients want to know, but they don't want to ask, and sometimes staff isn't comfortable talking to the patients about that. So again, if you refer them to this website, and you know, maybe in a talk or however you guys can get them here, if they don't feel comfortable asking those questions, you can just say, you know, if you're getting those hints by comments that the patients make, you can say, you know, why don't you go here and look under this one tab. I promise they'll find it, if that's something that they're interested in. And then take control. So on this one, what I loved about this was it talked about being their own self-manager. So just if you were CEO of a business, you have to manage your work. This one, you have to manage your body, and knowing, you know, when to call the doctor, and how to coordinate your exercise with your eating, and making it all work together. And then it talked about goal setting, steps to a successful change. I think I clicked on. Talked about how to set the goal. And then the one thing that I loved here in the toolbox is so preparing for change, developing an action one, and then my favorite was preparing for your doctor's appointments. And this did come from the American Heart Association, so again, they're doing all the hard work for us, and all this is there at our, for our resources. But, you know, when I know for myself, and when I educate the patients that are inpatient, you know, when you have your follow-up appointments, make sure that you write down your questions ahead of time and think about those questions. And so this kind of walks them through their plan, so that when they go to the doctor's office, they're more prepared. So, and then they also talked about what to do when you relapse. So if you had a vacation or something came up and you were sick and now you're just getting back into your exercise plan, you know, how do you navigate through that relapse and get back into the swing of things? So there's a video that actually talks about that as well. So those are the 5 pillars. Then they also have this Thrive 12-week challenge. This is something that I was thinking more for us in our cardiac rehab. If we don't have, you know, a structured exercise or education plan, this might be something that we could adopt. Again, I think it's just because of the 12 weeks that stood out for me. So cardiac rehab is 12 weeks, and so you could assign to your patients each week that they came in one of those blocks to do, and then that would be your talk for that week that went alongside with, you would give them homework to focus on, you know, how to start an exercise program, and then in the class setting, or while they're exercising, you talk that week about the exercise program. So it kind of ties it all together. So they have their own homework to do and to follow, and then it gives us that topic to talk about that week. And then that can kind of follow their 12-week exercise program. But the first week, maybe during their initial assessment or their intake, that's when you would assign for their homework the creative plan for change. And there's about a 4-minute video that starts to talk about how they start this cardiac rehab program and the Thrive weekly challenges, what they have to do, talks about creating that action plan, and how to you know, work through that, and what doesn't work at the end of the week, how do you make that better for the next topic that you choose. And then at the end, it does talk about how to maintain this healthy lifestyle. So you just spent the last 11 weeks in cardiac rehab. Now we're gonna give you your wings, you know, hopefully have you go off on your own, continue to do this healthy lifestyle, but it talks about maintaining and, again, what to do in case you did have a relapse and how to handle that. So how do we use this in cardiac rehab? What challenges might we face? So for us, we had already immediately, Ruben was the one to say, well, for Banner, our approved educational resource is CRAMES. So we are supposed to be giving out CRAMES material. So we, you know, said, well, we give out CRAMES, but we will also use this as a supplement for our education for the patients. So that might be a way that we can incorporate this, because I think this is a little bit, you know, better suited for the cardiac patient. It has a lot more information and resources for us to give them. So for us, for CRAMES, we could say that we could use this as a supplement. Or you can also give this as a resource to the patients to say, hey, you know, we still do our own education here in cardiac rehab, but this is something that I want you to look into at home on your own, and maybe, you know, follow through some of the plans. And also for our phase 3 patients, because sometimes I think that they get lost a little bit. They've already gone through cardiac rehab, and we kind of just, you know, not push them off to the side, but they're independent exercisers. So maybe we can utilize this for them as well and give them that as a resource to do. So, Rich, anything else that you got from it?
I think what, you know, we have choices there, there's selections. Even if you can get the patient to at least click on something, maybe your talk or your education for this week will say exercise, and they refer want to know something about stress because of their job or something going on. They can pick from here, and I think once you got them booked on doing this thing is phenomenal. You get in, I've had, since I've been back from the conference, I've given out all my free brochure things. I have the copies of them, but the patients love this. I mean, because this is up to date. They up to date with this and then especially having the difference of languages.
Right.
It's all right there for us. I mean,
It's not copyrighted?
No.
Nope.
And so we sat through, I mean, literally, we're sitting through this session, and I'm hitting it every 5 seconds. And I'm just saying, this is too good to be true. How much is this going to cost? You know, this can be free. And that's all going through my head. I mean, literally. And, you know, it was like a sales commercial. And he's this amazing speaker, and he's so vibrant. And it was, I mean, you just were so drawn to him while he was talking. And then one of the women in the session asked a question, and she said, and he had just given this mind-blowing, like I said, I wanted to give him a standing ovation. And she said, you know, I don't want to insult you, but what's in this for you? Like, you're telling us all about this, but there has to be a catch. And he said, I do this so that you can better your patients, and I do this so that I know that I'm helping patients. Now, he's also from Canada, and they have a foundation, I think, that runs this program. So, you know, they were able to put this together. But it is free. You can recommend it to all of your patients. You can utilize it in your hospital setting if I guess it is approved, or we kind of figure out how to manage that. And then they also have the Diabetes College, which I did not get into at all, but that's a whole other component of this. And I haven't had the opportunity yet to look through that, so I don't know. But if it's anything like this, I'm sure it's amazing. So the only thing that he asks is, as we share this information, he gets great joy by having the people that learn about this to take a picture. So that's the only thing that he has requested, is if we can all take a picture with the Healthy University in the back, and we'll pass that on to him, and he would be very appreciative. So, any questions about this, or do you want to, Steve, while I have it up? Any topics that you saw up there?
Can you pull up one of the sheets that they print out?
Mm-hmm. Yep. So one of them was getting active. So they had remember how I talked about the diaries? So this is one with their, if they were, because I always feel better, or feel that the patients would do better if they had a concrete piece of paper to follow. You know, it's one thing to say, oh, I'm going to exercise today, but if they had to write it down, or they had to follow, or maybe we assign this to a patient to do home exercise, and then they have to get it signed off, like they're in school again, you know, to show that they did do their home exercise to be compliant. So I think that one is really good. When I talked about the whole action plan with goal setting, this is what that plan kind of talks about. So my plan will include, what am I going to do, when am I going to do it, where am I going to do it, how much am I going to do it, how often am I going to do it, and there's a video that you can watch that gives an example. So it makes more sense if you have that visual aid that you can follow along, and then you're like, oh, that's how I set a goal. Because sometimes the patients don't even know where to begin, and it was as easy and as simple as just, I want to eat more vegetables. Well, how am I going to do it? When am I going to do it? At dinner time. You know, so he walks you through, or the video walks you through how to do goal setting and how simple it can be. And then if you didn't, maybe you had a goal to eat more vegetables 3 days a week, but you only did it 2 days a week, then how do you make it better for next time? And they walk you through that. So, I mean, I really think that this is some incredible stuff to do, and to give the patients. Then there was also the resistance training. That wasn't the exercise bands, but let's see. So they have, actually I didn't even see this one. So every little tab you click on is amazing. Exercise band, exercise poster that talks about how to use the TheraBands. And then there was one that had the resistance training diary. So all of those in that gallery with the videos that was on, that I had played that one, these are all of those. So if they just followed that, that's a whole resistance training program that the patients can follow at home.
I would say, even if you don't get your organization to allow you to do the education, just those handouts right there you just showed, everything's laid out. Print that out and use that as your regular weekly, why create the wheel? It's right there, and it's all done very, very well.
Everything that we think about, that the patients ask us about, is here. So how do you buy a proper running shoe? You know, what are the things that you want to look for? Why is it important to buy a running shoe? So that, to prevent injury. And then it talked about how often to buy them, and it went through with, I thought I read it. Page? Okay.
Let's see, where its shoes will last.
Oh, there we go. Oh, yeah. See? So they've thought of everything. And the best part is that maybe they didn't think of something. You could probably reach out to Dr. O and say, hey, this wasn't on there. My patients were asking about it. Could you probably add it? I'm sure that they make updates, and they would be more than willing to hear from all of us if we see that something should be changed or added. Anybody want to see anything else?
That's incredible.
Yeah, it's pretty cool, so. That was my favorite talk.
Awesome work, Janelle. If you could bring your USB.
We have to take a picture, but we can do that at the end.
Oh, yes. So what Stephanie presented on, I thought was a great educational resource there. And that is, it's so versatile regardless of the exercise IQ of our patients. So, we have the whole spectrum of exercise IQ, from those who are marathon runners to those who have never exercised a day. So those resources are universal and useful for everybody. So our next presenter that we have is going to be Janelle McCluskey. She is going to go over the topic of medical marijuana, e-cigarettes, and alcohol. So just give us a few minutes. We're going to get started with her slide presentation in 1 minute. All right, so let's give a warm welcome for Janelle McCluskey.
Hello there. My life would be as technologically savvy as Stephanie's, but I wanted to go to this particular topic because I didn't really feel like I have a lot of knowledge in marijuana, cigars actually is in there too, e-cigarettes and alcohol. So I'll tell you the notes and the little nuggets that I got, and these are some of the people that went with us to the presentation. And just to let you know, we were in Oregon, and I could have brought back treats, but I didn't. And I just want to let you know I'm not an expert in this. I'm just the messenger, so don't make the questions very difficult. All right, I did want to give credit to the people that gave the talk, so I did put up who they were and where they're from, so if you have any specific questions that you do want to ask, that would be the person that you would want to go and direct those to. So the first one was on medical marijuana, and they basically divided it or tried to give you an idea of what it was involved in. You got this THC, if you've heard all these acronyms out there, you got THC and CBD, and it's the THC one that is the psychoactive part, in case you were wondering. And then they talked about how it affects our bodies in the different ways from a cardiovascular perspective. I'm just going to let you give you a minute to read that without me having to read it to you. And then what it talks about is medical marijuana, and they did show a graph of all the different states that have approved marijuana medically and recreationally and both. And it's now, there's quite a few states out there. I couldn't get that to copy over, so you'll just have to take my word for it. There it is. That is the FDA has approved medical marijuana for those 3 conditions only federally, and then everything else is state regulated if it's going to be used for any other conditions. The potential harms of marijuana from a cardiovascular standpoint, these are the things that happens to our bodies with elevated systolic and diastolic blood pressures, our tachycardia, and they specifically identified atrial fib as that particular tachycardia that they were talking about, and delays the time to your angina, and the most highest risk of a heart attack was 1 hour after you use it. So there's a clear correlation with an increased risk of death. Next one was from a pulmonary perspective. Those of you that have pulmonary rehab, these are the things that are affecting our bodies from the pulmonary, and they're not sure yet if there's an increased risk of lung cancer or emphysema yet from it. So very little research on secondhand smoke. We know what it does from tobacco, but there's little research on marijuana smoke. And then these are the other effects that marijuana can have on us, affecting moods. So there's some association with stroke, and particularly if they combine it with tobacco. And that was one of the other ones that we'll talk about when we get to e-cigarettes, that most people are dual users. And so that's posing some other issues out there. How you consume it makes a difference. If you inhale it, it has a rapid response, and if you ingest it, it takes 2 to 3 hours to peak. Some of you may know this, some of you may not. Potency, back in the day, back in my days, 70s and 80s, the average THC content was only 3 to 4%, and nowadays it's between 25 and 50%, which is a huge range, and that's because it's not regulated. So that's a huge difference, just looking at it from age. And the cardiac clinical recommendations, if they were talking to your patients, if that's one of the things that they're using, they usually basically all the way from the cardiologist standpoint, all the way to the rehab standpoint, is there's 3 things that you can ask them to do. You can either tell them to stop altogether, and if they can't stop because they are using it for pain control or some other medical condition, maybe compromise on how they use it. But you need to at least discuss with them the risks, the pros and cons of doing it or not doing it. That was all on medical marijuana. So the next thing that they talked about was tobacco, and they specifically talked about cigars and cigarettes. And I really didn't know as much about cigars as I thought I did, because it seems like they've been around and they seem to be a pretty benign type of a tobacco product, but not necessarily according to their research. This again is the prevalence of smoking in general, is that people are use at least 1 or more tobacco products, and 10% are dual users. And most people use cigars and cigarettes, 37%. Cigar smoking hasn't increased though; it still stayed at the 2.3% between the years of 2000 and 2015. Here's some of the other graphics. So I thought that was pretty significant. So I put that up there for you there. 1 hour of hookah is the same as smoking 200 cigarettes. Smokeless tobacco contains 3.6 to 4 milligrams of nicotine, which is pretty high content. The cigar warnings: 1 large cigar is equal to 1 pack of cigarettes when you're talking about nicotine. And they said, and the reason they said large versus small is the large ones sit on the lip and it has such a large circumference, and it's absorbed consistently and constantly, whether you inhale or not, or whether you light it or not. So, and those are the other things, it doesn't have a filter. When they're the large ones, the smaller ones have a filter in it. It's still addictive, and now they're showing associated with heart conditions, stroke, and cancer, and then now they're showing the studies is an increase in COPD. And there's no safe level of cigar smoking, which we all know tobacco's bad, but I just didn't realize how bad. So in summary, we need to assess for all types of tobacco. It's crucial. Inhalation matters because it can cause serious risk, and no amount of tobacco is safe. So moving on to the other tobacco now is e-cigarettes. And again, there was 4 different presenters on this, but they were all from University of Vermont in some fashion. This particular one was, and this one I apologize, but I couldn't get the slides to copy over. They had a nice slide of showing you all the different types of e-cigarettes that you have. That ranges from the different mouthpieces. Some of them have liquids, until you eventually get to the very last one, which was the jewel one. There's a zillion different types and kinds out there, and I'm not really all that familiar with, but it kind of gives you a visual of what's out there. But those are basically the types that they were talking about. The chemistry on the laboratory data, basically it just depends on what kind of device and how and what it is that you're inhaling. And they don't really know from the nicotine, they can't tell if it's greater than, less than, or equal to cigarettes, so they don't really have anything to compare it to. Which is probably why we're having issues nowadays with our people out there in the health. So the summary on that one, research summary, there are definitely, that's associated with heart disease or cardiovascular disease. They're less toxic, but not chemical free. They still contain nicotine, but we still need a lot of research. So kind of generalizing the gist of the research there. And they wanted to, one of the other topics they wanted to address was if you could use e-cigarettes to lead to regular cigarette smoking, to helping them quit. And NRT is nicotine replacement therapy. And they say it's probably more effective, but you use it way longer than you use if you did the nicotine replacement. So then there's which one is better. Looking forward, don't do use. All right, moving on then to alcohol, which I thought initially was like, oh, we've already all heard all this kind of stuff, but they were putting it in a little bit different light and how it relates to cardiac rehab, which I thought was pretty interesting, and basically telling you actually what alcohol actually kills us, and of the top 3 things that kill the Americans, alcohol is number 3. And tobacco kills 5 to 10 times more people than opioids do. The other one, then here's what they're in the research that it's going to follow here. These are the terms that they're utilizing as far as what they're defining as moderate alcohol intake versus binge drinking. And nobody's going to admit to anything. That's just what it is. And then this is, are you all familiar with the J-curve? No. This is, well, and I guess from what I gathered from the talk, the J-curve is common knowledge as far as how they present moderate levels of drinking have been promoted as being healthy for you. So if you look at where the no-risk line is, and then how many drinks that you're taking, it says like 3 to 4 drinks per day would actually be beneficial to your health, and then above that, it becomes detrimental. Is that how you read that? So they call it the J curve, is that J part at the bottom is where the benefit is. But what they found out is that this research was based on putting people that had quit drinking and then people that had never drank into the same group for their baseline, and that skewed the results. And now when you took the former drinkers out and just had never drinkers on it, this is what you find. And that risk, or that benefit from drinking no longer exists. So to teach people to drink for healthy reasons is not accurate. So that's kind of that in a nutshell. I know, right? Didn't say you can't drink. So that 3 to 4 drinks a day increases your mortality substantially. But look at, there is light at the end of the tunnel there for those that are older. Age matters. At 60 years old, if you were an alcohol abuser, you've survived your alcohol addiction. How many want to stand up and do a happy dance? Yeah. All right, so basically the guidelines are saying that you don't recommend anyone to drink more frequently on the basis of health. There's no merit in alcohol consumption as a preventative strategy. Summary of that particular one. That they were biased. The studies all show it. I didn't show you all the studies. And problem drinking is common in our population, which I think we probably already know. Implications of that. We should always ask our patients about your alcohol use. Never counsel a patient to start or increase to reduce their cardiovascular risk. And if there is a problem detected, they should quit alcohol. And you would think that maybe we had too much to drink when we were on our trip. I won't mention any names. But no, we had not had anything to drink yet. But after we climbed that mountain, we did.
That was coffee.
Well, yeah, that was the day after. But that's it. That's it.
Excellent presentation, Janelle. That was awesome. That was very informative and kind of myth busting there on a lot of what's believed. All right, ladies and gentlemen, our next speaker is an exercise physiologist currently working at Mayo Cardiac Rehab here in Arizona. She is awesome, wonderful exercise physiologist. Welcome to the stage, Holly Bright.
All right, here's
part of our group that went to the conference. And oh, I see. So I should look at this. So this was one of the great sights we got to see. It's just outside of Portland. And we got our steps in that day. And it's always good to get into nature. And we did it. And we got our steps in. All right, so I had the privilege of going to Murray Lowe's talk. Every year that he's at the conference, he gives a synopsis of all the studies in physical activity and fitness and cardiac rehab that have been just off the press. And I am basically going to show you some of his slides and just kind of recap what he was talking about. So these are the research studies that were published in 2019 so far. So the first one is cardiorespiratory fitness, body mass index, and heart failure incidence. And if you want to refer to any of these, take a picture of that and you can take it home with you and use it in your cardiac rehab. So this was basically saying that the heart failure risk was significantly higher in the obese category, but was no longer significant after further adjustment for meds. So, you know, I think the shift of focusing on the patient's obesity or their body weight we're missing the mark. We need to focus on the fitness, and I think I'm preaching to the choir here, but just another study showing that. Okay, and that just shows you that's, oh boy, that's hard to see, I know. But the study strongly supports the concept that fitness overcomes obesity and strengthens the argument that much of the observed association between obesity and heart failure may be explained by low cardiorespiratory fitness. You know what, I'm thinking we should turn the lights off. That helps a little bit. Okay, the next study was just about physical activity and incidence of heart failure in postmenopausal women. And I skipped all the nice schematic X and Y axis and just gave you the conclusions here. That higher levels of recreational physical activity, including walking, were associated with significantly reduced heart failure risk in women. So I think we do a good job in cardiac rehab at explaining the FIT principle, and you got to do this and you got to do that, but just encouraging the patients to get out there and do more active recreational things. And this is exercise capacity and quality of life in heart failure. And basically it's saying that the more their fitness goes up in heart failure, which hadn't been looked at before, the better their quality of life. And I went to a couple of different things that talked about the frailty that Ruben was talking about. And they're encouraging us to look at that frailty. There's a couple slides here later, but just crossed my mind that the functional capacity of our patients is just as important as some of the cardiorespiratory fitness. And we should kind of work on that. And here in fact is one of the things I was talking about. So they're looking at falls. And this was a big group of studies, 21,000 participants, and they were women. The most used exercise was multi-component training with aerobic plus strength training, 50 minutes per session, moderate intensity.
and the exercise significantly reduced the risk of falls. So that's kind of a side benefit, and so they're going to stay more active longer and reduce the risk of fractures. And we know what fractures do to the elderly. Sometimes they don't make it out of the hospital, so the more injurious falls don't happen if they're a little bit more fit and strong. Okay, so that's showing you and the conclusions there. All right, and this is about the associations of resistance exercise with cardiovascular disease, morbidity, and mortality. And I found this really interesting because all these years, you know how, at least I have said, oh, aerobic exercise is the one that you want to do to reduce your risk of cardiovascular events in the future. And this is showing that independent of aerobic exercise, resistance exercise is helpful. And it doesn't have to be high frequency, it just has to be the 2 to 3 moderate frequency and amount of resistance training. I'm just wanting to tell you that these little words are really hard for me to read. Okay. So here's another one about the falls and physical function. And again, those living with declining physical function and chronic health conditions, we can't underscore the importance of physical activity as the adults age. Okay, and this was interesting. This just talked about women that were just told to go out and exercise and to do walking for their exercise. And their self-selected speed when they went out walking actually was in the parameters of what we tell the patients for the FIT principle. So they're self-selecting a speed that puts them in that moderate level of activity. So I thought that was interesting. And so that just shows you some of the statistics there. They inherently choose a walking speed that approximates the optimal intensity for inducing the health-derived benefits of regular exercise. Oh, and this, I think of anything in the whole conference, this was the one that stuck at me the most, or stuck out to me the most. How many of us asked step count for patients? And we are always saying, oh, you need to get 10,000 steps to really get the benefits of health, benefits of aerobic exercise for health. And we're finding that it was based on a Japanese study that was just promoting pedometer use. So when they look at the actual research, about 7,500 steps per day is where you see the best health benefit. And after 7,500, and that I'm just kind of estimating that value, but after 7,500 steps, it actually starts going down as far as the benefits. So I thought that was probably the most interesting thing I heard. And here's just a little commercial break. That's where we got our steps, going up the hill. That's Mount Hood, and we stayed at that lodge while we were there. Of course, on our own dime. So, and this is talking about the step counts, and it actually is a pretty big study. Over 17,000 devices were downloaded, and they looked at where the step counts are most effective. And the mean age was 72 years, and the mean step count was about 5,500 per day. But among older women, as few as 44,000 steps was shown to be able to lower mortality if they compared the results of someone that walked 2,700 steps per day. And there's a leveling at approximately 7,500 steps, so I wasn't off too far. Stepping intensity was not clearly related to lower mortality rates after accounting for total steps. So you didn't have to go faster, just get the steps in. All right, and this was interesting, and I don't know if anyone's thought about looking at, promoting steps a day when they're in the hospital. But this was a study that looked at 100 patients wearing activity monitors after inpatient surgeries, and this was more than cardiac, hip replacements and abdominal hysterectomies and other things. And the conclusion here was a higher step count of 1,000 steps on post-operative day 1 was associated with significantly lower odds of prolonged length of hospital stay, with no further decrease in odds after 1,000 steps. So this might be kind of interesting for those of us that see patients in the hospital to get over 1,000 steps. But post-op day 1, maybe that's soon, but interesting statistic. So who thought of using activity monitors in the hospital? And here's trends in sedentary behavior among the U.S. population. Let's see. So the conclusion is stop sitting. So everyone get up and just do at least a stretch real quick. Move those feet up and down. Okay, you can sit. Sitting was associated with all-cause and CVD mortality risk among those least physically active adults. So take the stairs going home. Moderate and vigorous physical activity dose equivalent to meeting the current recommendations attenuate or effectively eliminate such associations. So, this is nothing new to all of you here. And cardiac rehab fitness changes and subsequent survival. And this is saying that significant proportion of subjects referred to cardiac rehab had no improvement in cardiorespiratory fitness. So these are it didn't help in about 23% of our population. So what does that mean? How are we not reaching this 23%? So maybe we're not increasing their activity as much as we should, but there's non-responders in cardiac rehab. Have you guys heard about that before? I've never heard that before. So in other words, 23% had no increase in their MET level when they were in exercise. But it might be interesting to know if their time of exercise improved or maybe their functional capacity. Maybe their 6-minute walk test improved, or their ability to get through their daily living, or their sit-to-stands. So I don't think this shows the whole story. Okay. And so, Stephanie, I would just be telling patients, you can go to that new educational thing from Dr. Paul O. from Canada. But basically, if they're more fit, they're more sexually active, and they have better mortality. And again, Murray was showing us, and he's preaching to the choir, that cardiac rehab, a low tech, low cost. It's great medicine and we should continue to improve it. And this is Jane Langley doing her steps to get, maybe she went to the top of Mount Hood, I don't know, but she had a great effort there. So that was a quick rundown of some of the studies that Murray talked about. And it was always a whirlwind of information from him. And he is going to come and speak to us, hopefully, at our annual conference this year. So you'll get to see how effective he is in promoting our profession and physical activity. Thank you.
Thank you very much, Holly. That was very informative. All right. Well, in closing, we're going to talk, Stephanie and I are going to go back and forth on some closing remarks here. I just want to say, I had some advice from a colleague, long ago when I first started, and from Caitlin Davis, actually, who may be streaming in here. She had mentioned how important it was when giving a conference and talking about a conference about really delivering 70% of what people don't know and new innovative ideas, things that are really on our minds, and delivering that, and about 30% going over of what we already know. Okay, so that was a big part of putting on this conference. I hope those numbers are pretty similar to what you guys got from this message. TAVR being such an innovative procedure, it's definitely something we're going to see a lot more in the future. We have to be ready for it. That wave of low-risk patients hasn't necessarily hit us yet, but hopefully we've got a good foundation for what we're going to do as far as exercise prescription and moving forward and exercising those patients. So I'm going to hand the floor to Stephanie. She has a couple announcements, big announcements about our upcoming annual conference and also the fall conference. And then I'll talk a little bit more.
So we usually have our next quarterly conference in January, and years ago we tried to rotate. We would do one up north, one down south in Tucson, and I've been trying to reach out to the Tucson people to see if they want to get back into hosting the January meetings like they used to, and I haven't heard from anybody, and I'm not sure if anybody has a contact there at any of the Tucson medical centers or anything, but if we can't get Tucson, which I don't know if we will at this point, then if anybody's willing to host the January conference at their facility, just let either Lauren or Ruben know, and because they'll be planning the January meeting. And at this point in time, we do not have a location or a date, so as soon as we find that out, we'll let you know. And then real quick, just to give you an update on the annual conference, we are tentatively setting that date for April 4th, 2020. And we're tentatively planning it to be at ASU downtown location. And Ruben and I are going to be touring on Tuesday to confirm the location and the rooms, make sure that it's adequate for our space and our needs, especially with all of our vendor support that we've had recently. And that's kind of bridging that gap with ASCVPR's mission for finding the U, getting more schools and students into our society. And so we're hoping to partner with ASU for that, for our annual conference. So that's fingers crossed, it all works out. So it's going to be April 4th, 2020, and then again tentatively at ASU. When I was being in charge of the annual conference, I'm like, okay, well, we'll just have it back at Haley Heart Center because that's what we know and that's familiar to us. But I think they closed. If they are, yeah. So that's so sad because that was such a wonderful place and it was just familiar to us. But So we have to branch out and find new things. If anybody has, we're trying together, I'd like to not, put the conference off to the last minute. So potential speakers or sponsors or vendors, just send me an email and let me know if you have any recommendations. Andrea gave me one today, which is great. So, and then we do have Murray Lowe in the works that we're going to be getting him. I did also find out that we can get another speaker through ASCVPR that they would contribute for us as well. So that's another option. So I think we're going to have a great lineup of speakers. And if anybody has any suggestions or potential vendors or sponsors, just send them my way, please. Thanks.
Hey Stephanie, we probably could do it again.
Okay.
If we can't find a location.
Okay.
Yeah, if you can't find one.
Well, it sure is helpful, because that's the worst part, is just trying to, find a spot.
Okay.
So I'm putting my reimbursement chairman hat on right now. Just to let you know that our bill about making sure the sites for outpatient rehab are still grandfathered into reimbursement as far as getting reimbursed at the higher level and not the physician fee schedule. The bill that we've been working on for the last 3 years, we should have a bill number, and I will be sending out information for you to contact your senators and your representative to let them know how important that is for us. And I believe that the Karen Louie and some of the reimbursement gurus are saying this should be open to patients as well. So we can kind of fan out more support if we ask our patients to send in their email. So that will be coming soon, so just get ready.
Awesome, thank you, Holly. Holly is she is on top of all the legislation in regards to cardiac rehab. So if ever you have questions or if you want to get involved in knowing a little bit more about the legislation and cardiac rehab, Holly's a great resource for that. So in closing, this was a great conference. I had a lot of fun. I learned a lot, and I hope that you did too. Our live streaming service, thank you very much, Diane Wilson, for providing that. So I want to just talk about moving forward, and I have a lot of goals for this organization to continually move forward and take down some of the barriers that we face as a society. So one is coming down to these conferences. There's a lot of cardiac rehabs in Arizona, some of them farther away, such as Show Low, Lake Havasu, and we have the streaming service, and we hope that helps people tune in and make it a lot easier for people to come to these conferences and see them. So we also have a newsletter that we put out. The most recent newsletter highlights Lake Havasu, so definitely go take a look on the page for that. Finding You, it's an initiative set forth by the ASCVPR, and we want to partner with more universities, students, and get a lot of students involved in cardiac rehab in general, and here in Arizona. We all have an obligation to do that. I think this field is going to continually expand. It's going to rapidly expand pretty soon here, and we want to just involve some of the best emerging professionals out there. Speaking of emerging professionals, there's that emerging professionals membership that is out by the ASCVPR. If you are a new professional in the field of cardiac rehab, whether you're a nurse or an EP, if you're new within 2 years of being in cardiac rehab, there's excellent deals for joining and becoming a member of the ASCVPR. In fact, I think it's as low as $49 a year. So that's a steal. And that's going to help really get those professionals involved and give them the resources they need. So lastly, I leave you with, I am very open to new ideas, innovating, moving forward. So I'm open to any ideas. If you ever have any requests, ideas that you think would be good for the society, let me know. I plan on podcast here in the future, if you get a crazy email from one of my emails, whether it be podcasts about cardiac rehab, what's going on in Arizona, maybe short videos, our own education, tutorials, web platforms for us to communicate on, and just continually evolve and move forward. So I'm going to be ambitious and stand up for cardiac rehab, and we're going to continually move forward and get better as an organization to deliver the best possible care that we can to our patients. Thank you, and I hope you have fun at the conference.